IAH webinar. The first person to speak is Bruce Leff, the president of the Academy of Home Care Physicians. Bruce?
Thank you, Connie. We are getting a bit of an echo there, by the way. My name is Bruce Leff, and I'm the current president of the American Academy of Home Care Physicians, and I've been a House Calls doc for about 20 years now. And it's my great pleasure to welcome you to this really historic this first national discussion of the newly released CMS specifications for the Independence at Home demonstration, a program that we know will provide better health care now at lower cost to Medicare's most frail beneficiaries, those with chronic conditions. We firmly believe that IAH will not only significantly reduce costs to Medicare where they're the highest, but also improve quality of care and quality of life for Medicare beneficiaries and their family caregivers. Academy members have been working on IAH now for about a decade. So in these early days of 2012, we're very excited and very pleased that IAH is about to launch and that it'll be available to practitioner groups of all sizes. We'd like to go out of our way to thank our sponsors in Congress, Congressman Ed Markey of Massachusetts, Senator Ron Wyden of Oregon, for their leadership in getting IAH enacted as part of healthcare reform in the Affordable Care Act, as well as to many others who provided bipartisan support to get IAH passed. We'd also like to thank CMS Acting Administrator Tavener and CMS staff who worked very hard to get the specifications out in a timely way. And we'd also like to thank members of the IAH Coalition who supported the development of the IAH legislation, specifically the National Partnership for Women and Families and their president, Deborah Ness, the National Family Caregivers Association and its president, Susan Mintz, AARP, the Alzheimer's Association, the American Nurses Association, Intel and the Continua Alliance, and many others. And finally, to thank the Retirement Research Foundation for sponsoring this webinar. We're going to try and pack a lot in this next hour. First, Academy staff Connie Rowe and Gary Swartz will briefly review the good news about the specifications, how to make financial decisions and the pending issues. And then we'll have the IAH creative team, including Jim Piles, George Toller, Peter Bowling, Bruce Canosian, and I think maybe Gresham Bain to give you some brief discussion on critical factors for success for proposals. And there will hopefully be some time at the end for questions and comments. If you have questions, you can click on your GoToWebinar navigation panel on the right and type in your question, and we'll get to those towards the end of the webinar. And now for our first speaker is Executive Director Connie Rowe.
Unmuted. My job is to talk about some good news about the IAH specifications. Bruce talked about how very hard the IAH creative team has worked and the relationships that they have developed. He is included among that group, and the work that has been done is clearly spectacular, and we are very, very happy that CMS has accepted so many of our recommendations. Just to hit the highlights, eligibility determined by the program, not by lists given by CMS, is yes. Flexibility in selecting 2+ chronic condition diagnoses instead of just a list. The use of post-acute care interpreted to include home health in the specification of acute or subacute rehabilitation. The payment methodology. There is a way to allow for small programs to participate, and there had to be, we felt, a real incentive for participation. So you'll see that that 80-20 split that we've talked about forever is, in fact, one of the options. The risk, other aspects of the payment methodology, we at least had a partial victory. The risk methodology should be based on public plan methodologies, HCC scores plus frailty adjusters. We had asked for quarterly periodic payments. At least we got better than the end of the demonstration. The first payments will be made after 18 months. We also felt very strongly that quality measurement should be pertinent to this population and limited to the most important and proven measures, and that was in fact included. Technology in the 24/7 requirement should be broad, not restrictive. And other good news, that there is an explicit way for home health agencies and other providers to joint venture with practices, and it provides a way for practices of varying sizes to participate. So we believe that that's all very good news. And now the next speaker will be Gary Schwartz of our staff, who is going to talk about walking you through a financial model of what this all means. Gary?
Good afternoon. My name is Gary Schwartz, Associate Executive Director of the Academy. And as Connie Rao mentioned, I'm going to walk through a financial analysis and should my practice participate. Next slide, please. This afternoon's discussion is a continuation and application of the planning process we began last summer on whether to develop IAH capacity. The financial analysis will use published CMS specifications and field evidence that supported IAH's development. And then we'll close with a couple of observations regarding potential high-cost IAH-eligible beneficiaries you may already be treating or may be able to identify. Next slide, please. And these slides, as well as the entire webinar, will be posted to the site. The IAH specifications, CMS provides for 3 models to participate in the demonstration. One may participate as an individual practice, as a consortium participant, or as a member of a national pool of practices with 200 to 500 IAH beneficiaries. And Jim Powles will also discuss these models later on in the presentation. Next slide, please. CMS will pay practices based on savings that exceed a savings threshold and also on quality measures. CMS minimum savings requirements are based on practice size to assure that the savings are not by chance. And what this slide reflects is that the smaller the practice, the greater the savings required to prove that the savings were not due to chance. And conversely, the larger the practice size, the smaller the percentage to prove that the savings were not due to chance. And for those in smaller practice settings, you'll see that your thresholds to demonstrate demonstrable program savings are higher than the larger programs. Next slide, please. And as mentioned, the second major area that's going to be evaluated as part of your program performance will be quality measures. Of the list that's on this slide, the top 6 will be considered for payment purposes. All of the measures will be used in determining program evaluation. However, again, the top 6 will be included for payment purposes, and we will discuss that in a little bit more detail in a moment. Next slide, please. The payment methodology uses a buildup of a spending target. Moving from the left of this slide to the right, CMS requires a minimum of 2,400 beneficiary months per year. This produces an average monthly beneficiary volume of 200. So they are not using an absolute cutoff of 200 IAH eligible beneficiaries, but one must achieve an average monthly beneficiary volume of 200. And so that is the 2,400 beneficiary months per year divided by the 12 months equals the 200. The next factor that CMS is going to use in their payment formula is the average fee-for-service cost in the county of residence. We have plugged in a national figure. CMS also uses the county rates to pay Medicare risk programs, or at least now to support the bidding process for the Medicare Advantage programs. The next factor is going to be the trends that include the risk adjustment score and a frailty factor. This rolls up to what is the CMS HCC model. Dr. Kanosian has presented on this at the Capitol Hill presentation. That presentation is on the site. And the number that we've plugged in here is based on PACE and Elder PAC demonstrations. We multiply that by the number of months, and in this presentation we come up with a projected Part A and Part B spending target of $7,020,000. Next slide, please. So our practice-specific Part A and Part B spending target for 200 average beneficiaries per month is the $7 million. On a feasible yet aspirational example of 25% savings that field evidence, again from your programs, has demonstrated, that produces a savings of $1,755,000. According to the specifications in the legislation, CMS retains 5% of the savings off the top. That 5% of the savings is off of the $7 million. That's our $351,000 figure, leaving a remainder for distribution based on satisfaction of the quality measures of $1,404,000. Next slide, please. Of that $1,404,000, if we've satisfied 100% of those top 6 quality measures, the practice would share in 80% of the savings, which produces the number of $1,123,000. If the practice has satisfied 50% of the quality measures, the practice would receive half of that $1,004,000, which is the $702,000 amount. Next slide, please. As we continue into the analysis, we also want to put in a figure of what is our practice cost. And we are going to use for this afternoon's example a beneficiary example of $200 per month of additional cost to be an IAH practice. And that $200 could be spread across staffing, care coordination, technology, pharmacy consults, any range of services that you are rendering to your IAH beneficiaries or eligible beneficiaries. So we have the practice cost of $200 per beneficiary per month on the left-hand side. This amount also was suggested to CMS as an interim payment amount. CMS has decided not to go with any interim payments. However, we're going to use this as our cost figure. We multiply that by the beneficiary volume to get to a monthly cost of $40,000. Multiplying that out equals an annual additional cost of $480,000. Next slide, please. Using our figures before of whether we've achieved 100% of the measures or 50% of the measures, we subtract the $480,000 of additional cost from our $1,001,000 or our $700,000, and on the right-hand side you see what would be the profit that is received by the practice depending on your satisfaction of the quality measures. $643,000 if you've met all of the quality measures, $222,000 if you have not received, if you have satisfied half. Drilling down, next slide please. Drilling down to a per beneficiary level, we take those figures and divide by the number of beneficiaries, and we can see that in essence the shared savings or profit for per beneficiary, $56.15 if we satisfied all the quality measures, $35.10 if half of the measures were satisfied. Next slide, please. We wanted to also present what is a break-even analysis, and that is what amount of savings would be required in order to satisfy that $480,000 cost build-up to be an IAH practice. That amount on this slide is 13.55% of savings. So if we take that off of our spending target of $7 million, that produces $951,000. CMS, again, takes that same 5% off the top, $351,000, leaving a remainder from the $951 of $600,000 for distribution. If we've met 100%, going down to this next second level there on the chart from the left-hand side, the remaining savings of $600,000. If we've met 100% of the measures, we receive 80% of that $600,000 amount, which is that $480,168, and we've had our program build-up cost of $480,000, leaving a profit of $168, or essentially our practice experience has been a wash here. If, on the other hand, we've only met half of the measures, we received $300,000, and as compared to our additional cost of $480,000, we can see that there's actually a loss of dollars in that example. So our break-even for practices at the 200 beneficiary level is a savings of Part A and Part B cost of at least 13.55%, and then a satisfaction of each of those 6 quality measures. Next slide, please. So some key considerations on your participation decision. Is the practice already operating at an IH level in terms of services and in terms of costs? So perhaps that $480,000 isn't an additional cost, but you're already operating at that level. Number two, is the practice already treating IAH-eligible beneficiaries? Or is there regular inflow and referral of eligible beneficiaries? If not, does this mean you'll have to market and identify beneficiaries? Third, can the practice absorb, wait the 18 months for initial reconciliation and payment of shared savings that Connie Rao described and as the specifications provide? If you're already operating at the level and the services and costs and beneficiaries are available, then there's less risk, and there also is no payback requirement, so you're in a much better starting position. Next slide, please. As we know, and also this information is from a CMS source book, that the more chronic conditions of beneficiaries, the greater the Medicare cost, and the more likely the beneficiary has been hospitalized during the year, has had an ER visit during the year, or has been readmitted within the past 30 days. Next slide, please. What you'd want to do to take a look to see if you have an IAH then eligible beneficiary population is to take a look at the diagnostic codes on the left-hand side of this slide. This reflects in descending order those diagnostic codes that have relationship with multiple chronic conditions. And again, this relates also to the cost of that beneficiary, the hospitalization, ER admission, and readmission potential, et cetera. So going down from heart failure down to depression. What you'd want to do is query your practice information systems for diagnostic codes related to those high-cost beneficiaries, and then you also want to review your Medicare payment source to assure that they are in the traditional fee-for-service program, as the IAH program is going to exclude Medicare Advantage plans. So you want to make sure that you're considering Medicare beneficiaries that are in the traditional program. Again, this presentation will be posted, and that completes the financial analysis for this afternoon. Thank you.
Good afternoon, everyone. I'm Jim Piles, and thanks, Gary, for a great presentation there. Just in a summary statement, I think you can see there that the potential downside risk under the Independence at Home program is rather limited, while the upside potential can be rather significant. I thought what I would do is just touch a little bit on some of the legal issues that might help you decide whether to participate in an Independence at Home organization, and if so, what you'll need to do that from a legal and practical standpoint. Could I have the next slide, please? So why participate? Just very briefly, the home health, or the healthcare reform models that are likely to reduce costs are the ones that are going to prevail and have the greatest longevity. Ironically enough, Independence at Home is the only health reform model under the reform legislation that requires any level of savings. It is also the only health reform model that is targeted to the highest cost patients and that cost where they appear in the Medicare continuum. It can be immediately implemented with very relatively little cost and little ramp-up time. And it's proven to reduce costs rather substantially. And Gary's touched on that a bit, but we've seen programs that varied from 25% savings up to 60%. And the risk-reward balance, as I mentioned, is relatively high, and there is no cap on the savings sharing that you can receive. Next slide, please. A question that we've gotten a lot is, can an organization participate in both an ACO and an Independence at Home organization? The legislation says that if you participate in a number of programs, including Independence at Home, that you then cannot, as a provider or practitioner, participate in an ACO. The ACO regulations, though, make it pretty clear that you can actually participate in both if you have different tax ID numbers for participating in one and a different tax ID number for the other. And I've given you the Federal Register site for that. You can also participate in an Independence at Home demo, and you can participate in an ACO program later. So you can participate sequentially. You could participate in an independence at home program and drop out and then go into an ACO if that was your choice. You can also participate in ACOs and independence at home for Medicaid. It only applies, the prohibition on duplicate participation only applies to Medicare. You can also participate in the integrated care programs that are being established for dual eligibles. So you can you wouldn't be disqualified there. You can participate in both ACOs and independence at home. Can you withdraw from an independence at home organization without penalty? Probably yes. We don't know the answer to that for sure, but there's nothing to indicate that you could not. Next slide, please. What legal entity? You should look at the legal entity first that's going to be participating in the independence at home program and determine whether it complies with the Medicare and Medicaid state and anti-kickback, Medicare and Medicaid state and anti-kickback referral laws. I think we've got a dog on the line here. I'm glad to see that our appeal is so broad. CMS has the statutory authority to waive these laws for independence at home as they do for accountable care organizations, and we're still waiting to see what those waivers will look like, but we expect to see them soon. Will you be including other providers such as home health agencies, hospitals, SNFs? If you do, you want to make sure that your contracts comply with the state corporate practice of medicine laws. Next, please. As Gary mentioned, there are 3 options for participating in the Independence at Home program. Option 1 is for the individual primary care practice. Number 2 is for a consortium of primary care practices over serving a geographic area. And number 3 is for practices of 200 to 500 patients participating in a national pool of providers or practitioners run by CMS. You'll have the least control over the savings sharing you receive under option 3 and the most control under option 1. Next slide, please. You'll need to consider as you put these programs together how savings sharing payments will be allocated among the participants, and that should be spelled out in contract. You need to determine whether you can meet the minimum requirements for participation in an IAH organization, and I've listed those for you. As Gary mentioned, an average census of 200 eligible beneficiaries in each of the 3 years, ability to provide health care in the beneficiary's home or place of residence. Next slide, please. Services available at least to some extent of 24/7, use of electronic records, remote monitoring, and mobile diagnostic technology. CMS has indicated to be somewhat flexible on the beginning ability to do that, and then the ability to report and quality measures. You're also going to have to be able to provide, of course, all the other information required for an IAH application, and we'll be providing a list of that for folks to see on the website. The Academy website. Could we have the next slide, please? Remember, the most important element or criterion for participating in the demonstration is going to be experience, providing home-based primary care to beneficiaries with multiple chronic conditions. We were very clear on drafting that into the legislation that should be given the most weight, and CMS did agree with that. So you need to show success in reducing costs, improving outcomes, patient caregiver satisfaction. This does not have to be rigidly peer-reviewed data, but you should have some information to show that you know what you're doing. You should show that your organization is uniquely positioned to provide care in certain high-cost areas, rural and urban areas, and with specific eligible beneficiaries. And you need to be able to show the practice will be ready to roll by the time of the application, which, by the way, is February the 6th for the individual practices and in the national pool. And by May the 4th, the application has to be submitted for the consortium. Next, please. Here are the legal documents you're going to need, and they're pretty self-explanatory, but there's going to be some knotty issues there, particularly if you have a consortium and you're trying to agree among a number of different practices how the savings will be distributed, who will be liable perhaps for losses, and under what circumstances can some practices actually be expelled. You may need to consider that. Certainly some services will be provided by contract with home health providers, physical therapists perhaps, mental health, social workers. So you'll need to have those contracts in place by the time of the application. Next slide, please.